Okay, so yeah, good evening everyone. Hope everyone is doing good. So, in the previous class, we have discussed about liver, gallbladder, and bile duct related pathologies. Now, today we are starting with pancreas, and in part 1, we are going to discuss some of the important pathologies of pancreas which we deal in everyday life. Okay, starting with pancreatic divisum. Okay, before that, we need to know certain anatomy related to pancreas. So, where is it located? Pancreas. Pancreas is basically located in the C shape of the duodenum. Okay, na? So this is first part. This is second part. This is third part. This third part further continues and it becomes fourth part. Like the first part, second part, third part, and this is fourth part of duodenum. So it is basically located in the C curvature of the duodenum. Okay, na? ಈ ಥರ ಇರುತ್ತೆ. Okay, and it has two ducts basically. So it is an exocrine gland. Okay, ಎರಡು ಡಕ್ಟ್ ಇದೆ, ಒಂದು ಮೇಜರ್ ಡಕ್ಟು ಇನ್ನೊಂದು ಮೈನರ್ ಡಕ್ಟ್. ಸೊ ದ ಬಿಗ್ ಒನ್, ದಿಸ್ ಈಸ್ ದ ಮೇಜರ್ ಡಕ್ಟ್. ಆ್ಯಕ್ಚುಲಾಗಿ ಹೇಗಿರುತ್ತೆ ಡೆವಲಪ್ಮೆಂಟ್ ಆಗಿರೋದು ಹೇಗೆ ಅಂದರೆ ಇಟ್ ಈಸ್ ಲೈಕ್ ದಿಸ್. ಓಕೆ, ಸೊ ಇಷ್ಟು ಒಂದು ಡಕ್ಟ್ ಆಗಿರುತ್ತೆ. ದೆನ್ ದಿಸ್ ಡಕ್ಟ್ ಡೆವಲಪ್ಸ್ ಸಪ್ರೇಟ್ಲಿ. ಓಕೆನಾ? ಸೊ ಬೇಸಿಕಲಿ ವಿ ಶುಡ್ ನೋ ದ ಡೆವಲಪ್ಮೆಂಟ್ ಆಫ್ ಪ್ಯಾಂಕ್ರಿಯಾಸ್. ಸೊ ಡೆವಲಪ್ಮೆಂಟ್ ಹೆಂಗಾಗಿದೆ ಅಂದರೆ ದಿಸ್ ಈಸ್ ದ ಸೆಕೆಂಡ್ ಪಾರ್ಟ್ ಆಫ್ duodenum. ಓಕೆ, ಇದೆಲ್ಲ ಯಾಕೆ ಹೇಳ್ತೀನಿ ಅಂದರೆ ಐ ಆಮ್ ಜಸ್ಟ್ ಬಿಲ್ಡಿಂಗ್ ಅಪ್ ಆನ್ ದಟ್ ಕಾನ್ಸೆಪ್ಟ್ ಅಷ್ಟೇ. ಇಫ್ ಐ ಡೋಂಟ್ ಎಕ್ಸ್ಪ್ಲೈನ್ ದಿಸ್ ವಿ ವೋಂಟ್ ಗೆಟ್ ದ ಪ್ಯಾಥಾಲಜೀಸ್ ವಾಟ್ ವಿ ಡಿಸ್ಕಸ್ ಟುಡೇ. ಸೊ ಐ ಆಮ್ ಬಿಲ್ಡಿಂಗ್ ಅಪ್ ಆನ್ ದ ಕಾನ್ಸೆಪ್ಟ್, ಪ್ಲೀಸ್ ಪೇ ಅಟೆನ್ಷನ್. ಓಕೆ, ಸೊ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಡೆವಲಪ್ಸ್ ಫ್ರಮ್ ಟೂ ಬಡ್ಸ್. ಆಯಿತಾ? ಡೆವಲಪ್ಮೆಂಟ್ ಫೇಸ್ ಇನಿಷಿಯಲಿ ಎಂಬ್ರಿಯಾಲಜಿ ಓದುವಾಗ we would have studied like pancreas develops from two buds. One is ventral bud. So this is ventral region, ventral bud of pancreas, and the other one is dorsal bud. ಓಕೆನಾ? ಸೊ ಈ ಥರ ಎರಡು ಬಡ್ಡಿಂದ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಫಾರ್ಮೇಷನ್ ಆಗ್ತಿರುತ್ತೆ. ಒಂದು ಮುಂದೆ ಇರುತ್ತೆ ಡಿಯೋಡೆನಮಿಂದ, ಇನ್ನೊಂದು ಹಿಂದೆ ಇರುತ್ತೆ. ಒನ್ ಈಸ್ ವೆಂಟ್ರಲ್ ಆ್ಯಂಡ್ ಅದರ್ ಒನ್ ಈಸ್ ಡಾರ್ಸಲ್. ಸೊ ಆ್ಯಸ್ ದಿಸ್ ಮಿಡ್ಗಟ್ rotates, what will happen? This ventral bud will come and join here. Okay na? So as the midgut rotates, whatever the ventral bud is there, that will come and join along with dorsal bud. So basically that will become like this. Okay na? So this is ventral bud and this is dorsal bud, which has joined now. Similarly, ventral bud will be having a duct, that is, dorsal bud is having a duct that is called dorsal duct, and ventral bud is having a duct that is called ventral duct. Okay na? So when it joins like this, what will happen? Dorsal duct will be like this till here. Below that there will be ventral duct. Okay na? And gradually it will establish a connection like this, and it will become in such a way that it will appear as if this is the main duct and the other duct is accessory. ಗೊತ್ತಾಯ್ತಲ್ವಾ? Initially the major duct was this one, that is the dorsal duct. But as the rotation occurred and ventral bud came to the side, the dorsal duct and the ventral duct combined and formed the major duct, and whatever the dorsal duct was there, the remnant, it will form a minor accessory duct. Okay, so it's like this. So basically there are two ducts now. One is opening in the upper part of the duodenum. Okay, so this is opening here, and the other one is opening below here. This we have discussed along with common bile duct. Okay, like common bile duct illinda hinge open bandu it will join major pancreatic duct, and this is major duodenal papillae. Okay, now this is minor pancreatic duct. So basically there are two pancreatic ducts, major pancreatic duct and this is minor pancreatic duct. Okay, now ಇಷ್ಟು ಗೊತ್ತಿರಲಿ. Major pancreatic duct is opening in the ampulla of Vater or major duodenal papilla, which is below, and this is a minor pancreatic duct which is opening above in the duodenum. Okay, now we'll study the parts of pancreas. So whatever the pancreas, the ventral bud which has come here after rotation, this leads to formation of head, and along with that it gives rise to a process called uncinate process. Okay, na? Whatever the dorsal bud which was staying there already, that leads to formation of neck, body and tail. Okay, so these are the parts: head, uncinate process, neck, body and tail. These are the parts of pancreas. Okay, so ishtu godagide. Now we'll start with pancreas divisum. What is this pathology basically? Pancreas divisum is the most common anomaly of congenital anomaly of pancreas. Andre ಹುಟ್ಟುವಾಗಲೇ ಬಂದಿರೋದು ಒಂದು congenital anomaly. What is happening here is it is characterized by divided drainage of the pancreas. Basically what happens, the pancreas along with the rotation of the gut should become like this. But if there is no rotation of the gut, there will be two separate pancreas, and this is called as pancreas divisum. That is, there is separate drainage of pancreas. There is two separate openings of the pancreas in the duodenum. This itself is called pancreas divisum. What will be the problem if there is two separate pancreas? ಏನಾಗುತ್ತೆ, ಆಯಿತು ಎರಡಿದೆ, ಒಂದೇ ಕಡೆ ಫ್ಯೂಸ್ ಆಗೋದ್ರ ಬದಲು ಎರಡಿದೆ, ಏನು ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ? It will lead to recurrent attacks of acute pancreatitis because of relative obstruction. ಎರಡು ಸೈಡಿಂದ if there are two different pancreas, there will be increased tendency of obstruction of this pancreatic ducts, which will in turn lead to inflammation of pancreas called acute pancreatitis. Hence, this is an important pathology. Okay, so yeah, just like I discussed, from the dorsal bud there will be body and tail, and a part of head or neck will be formed, whereas from the ventral head a part of head and uncinate process will be formed. So this I have explained while drawing the diagram also. I'll just explain it once again here. Okay, so basically yeah, so this is the main pancreatic duct, correct? Adadmele from the other way this ventral duct came and it joined and it became a major pancreatic duct, or this is the main pancreatic duct now, and whatever the duct was there remnant became the minor pancreatic duct. So this is the major duodenal papillae below, and the upper one is the minor duodenal papillae. Okay, if there is pancreatic divisum, if the gut won't rotate or if the rotated bud won't fuse, like this also is possible. Okay, so if it doesn't fuse, the dorsal duct is separate and the ventral duct is separate, so that will lead to two different drainage of the pancreas into duodenum, and hence this dorsal duct there will be more secretions through this duct, whereas this opening will be small, because of which there will be relative obstruction. ಆಯಿತಾ, ಓಪನಿಂಗ್ ಸಣ್ಣದಿದೆ ಬಟ್ ಸೆಕ್ರೇಷನ್ಸ್ ಜಾಸ್ತಿ ಈ ಪಾರ್ಟಿಂದ ಬರ್ತಾ ಇದೆ, ಅವಾಗ ಏನಾಗುತ್ತೆ, ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗೋದು ಜಾಸ್ತಿ ಆಗುತ್ತೆ ಕಂಪೇರ್ಡ್ ಟು ದಿಸ್ ಓಪನಿಂಗ್ ವಿಲ್ ಬಿ larger one, but there is less secretions, because of which there will be increased tendency of acute pancreatitis. Hence it is a major issue. Okay, so that's what they are saying. Major part of the pancreas is drained by accessory duct via minor papillae, whereas small part of the pancreas is drained by major duct of Wirsung via major papillae, because of which there will be relative obstruction leading to recurrent attacks of acute pancreatitis. So how will we diagnose this? Diagnosis, investigation of choice is basically MRCP, whereas as we all know, gold standard is ERCP, because in MRCP we can only diagnose, whereas in ERCP we can diagnose and treat it there itself, because we are going through endoscopy. Okay na? Hence gold standard is ERCP, whereas investigation of choice is MRCP. Okay, so what is the treatment we will do actually? Endoscopy ಆಯಿತು, ಏನು ಮಾಡ್ತೀವಿ endoscopy ಹಾಕಿ? We will do endoscopic sphincterotomy. That is, if there is relative obstruction, we will clear that obstruction by creating an opening. Creating an opening is called otomy. Otomy ಇಂದ ಎಂಡ್ ಆಗ್ತಿದೆ ಅಂದರೆ we are creating an opening ಅಂತ. Or dorsal duct sphincteroplasty. Just like angioplasty, sphincteroplasty ಅಂದರೆ ಸ್ಪಿಂಕ್ಟರ್ ಒಳಗೆ ಒಂದು ಸ್ಟೆಂಟ್ ಹಾಕ್ತೀವಿ. Putting a stent to the sphincter. ಯಾವ ಡಕ್ಟಿಗೆ? That is to the dorsal duct, which is the dorsal duct here. Because the opening is small, we are creating an opening in the dorsal duct, or we are putting a stent in the dorsal duct, so that there is no obstruction and there is easy passage of whatever the secretions are there from the pancreas. So that is the treatment. So we are done with pancreas divisum. So this is the first pathology, that is pancreatic divisum. Okay, so now second one, that is annular pancreas. So just like I have explained before, if there is no rotation of the pancreatic buds, like ventral bud is on the one side, dorsal bud is on other side, and just like we all know, intestine is soft in nature, right? Pancreas is a bit hard, and what it might lead to is it can constrict this duodenum. It can press and constrict the duodenum, leading to duodenal obstruction. That is a major issue if there is annular pancreas. Annular pancreas andre basically it is like covering the duodenum. Okay na? So basically this is the duodenum and pancreas is encircling this duodenum. So if the pancreas is encircling, it is called annular, throughout or surround anta. So annular pancreas, what will it do? It will lead to a ring of ventral pancreas is present around the second part of the duodenum, and this is located proximal to the ampulla. What is ampulla here? Ampulla is nothing but ampulla of Vater, that is this region where the duct opens. So basically pancreas is encircling the second part of the duodenum in this region, which is above the ampulla of Vater. Okay na? Usually this is associated with Down syndrome and duodenal atresia. Okay, what will be the problem? How will the patient present now? If there is obstruction, food can't pass through the intestine, correct? If there is no passage of food through the intestine, whatever the food he is eating will be put out through reflux, that is non-bilious vomiting will be there, as there is obstruction which is proximal to the ampulla. Okay na? Because of which there will be non-bilious vomiting aste. So how will we diagnose this? Investigation of choice is again ERCP. What will we do? We'll do duodenostomy or duodenojejunectomy. So basically what we are doing is, see, this is the duodenum. ಓಕೆ, ಇಲ್ಲಿ ಆ್ಯಂಪ್ಯೂಲ್ ಆಫ್ ವೆಟರ್ ಇದೆ ಅಂತ ಅಂದ್ಕೊಳ್ಳೋಣ. ಸೊ ಇದ್ರ ಮೇಲ್ಗಡೆ ಇರೋ ರೀಜನಲ್ಲಿ ಪ್ಯಾಂಕ್ರಿಯಾಸು ಅಬ್ಸ್ಟ್ರಕ್ಟ್ ಮಾಡ್ತಾ ಇದೆ ಡುವೋಡೆನಮ್ನ. ಸೊ ವಾಟ್ ವಿಲ್ ಡೂ ನಾವ್ ಈಸ್ ವಿಲ್ ಕಟ್ ಆಫ್ ದಿಸ್ ಪಾರ್ಟ್ ಆಫ್ ದ ಡುವೋಡೆನಮ್. ಓಕೆನಾ? ವಿಲ್ ರಿಮೂವ್ ದ part of the duodenum which is there within the pancreas. Basically it is like a ring, right? If we are seeing from above, this is pancreas or this is duodenum, yeah, like basically this is duodenum and pancreas is surrounding it. Okay na? So now we will remove this part of the duodenum and connect it from above. So duodenum, that is connecting the duodenum to remaining duodenum, that is called duodenostomy. If most of the part of the duodenum is covered, then we will join duodenum to jejunum, which is called as duodenojejunectomy. That is a treatment. Whichever the part of the duodenum is obstructed, we will cut it off and join it, rejoin it. That is the treatment aste. Okay na? So simple. So we are done with second pathology, that is annular pancreas. Okay, now third one, duodenal atresia. What is this? Similarly, there in annular pancreas, pancreas was obstructing the duodenum, whereas in case of duodenal atresia, improper formation of duodenum is there, or there are some other causes because of which duodenal obstruction has happened, and this is most common cause of neonatal intestinal obstruction, and this is located distal to ampulla. In case of annular pancreas, obstruction was proximal to ampulla, correct? Whereas in case of duodenal atresia, obstruction is distal to ampulla. So what difference does it make? Based on clinical features. I mean, if there is obstruction is proximal to ampulla, then the vomiting will be non-bilious. ಅಂದರೆ ಗ್ರೀನಿಶ್ ಇರಲ್ಲ, ಬೈಲ್ ಮಿಕ್ಸ್ಡ್ ಇರಲ್ಲ. ಯಾಕೆ? ಬೈಲ್ ಎಲ್ಲಿಂದ ಮಿಕ್ಸ್ ಆಗೋದು? ಬೈಲ್ ವಿಲ್ ಬಿ ಜಾಯ್ನಿಂಗ್, ವಿನೋ ಅಲ್ವಾ, ಕಾಮನ್ ಬೈಲ್ ಡಕ್ಟು ಇಲ್ಲಿ ಬಂದು ಆ್ಯಂಪ್ಯೂಲ್ ಆಫ್ ವೇಟ್ರಿಂದ ಇಲ್ಲಿಂದ ಕೆಳಗಡೆ ಇರೋ ಫುಡ್ಡಿಗೆ ಬೈಲ್ ಮಿಕ್ಸ್ ಆಗೋದು. ಸೊ ಇಫ್ ದ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಈಸ್ ಡಿಸ್ಟಲ್ ಟು ampulla, then bile will be mixed in the food and it will be bilious. So in case of duodenal atresia, vomiting will be bilious vomiting, ಅಂದರೆ bile mixed vomit ಅಂತ ಅಷ್ಟೇ. In case of annular pancreas, since it is proximal to the ampulla, it will be non-bilious vomiting. So just based on the clinical feature, without doing any investigation, we can differentiate duodenal atresia and annular pancreas, and hence this feature is important. This point is important. Aita? If it is non-bilious vomiting, then it is annular pancreas. If it is bilious vomiting, then the obstruction is distal to the ampulla and hence it is duodenal atresia. Okay. So what is the treatment? Again same. Whichever the part of duodenum is obstructed, we will remove that part and connect it to remaining normal duodenum. That is duodenostomy or duodenojejunectomy. Okay. So okay, after this, in abdominal x-ray, okay, these are some of the identifying features. Okay, now if there is a single bubble appearance in case of abdominal x-ray, abdominal x-ray ಮಾಡಿದಾಗ ಜಸ್ಟ್ ಒಂದೇ ಒಂದು ಗ್ಯಾಸ್ ಬಬಲ್ ಥರ ಕಾಣ್ತಾ ಇದ್ರೆ ಇಟ್ ಈಸ್ ಕಂಜನೈಟಲ್ ಹೈಪರ್ಟ್ರೋಫಿಕ್ ಪೈಲೋರಿಕ್ ಸ್ಟಿನೋಸಿಸ್. ಇದರಲ್ಲಿ ಏನಾಗಿರುತ್ತೆ, ಸ್ಟೊಮಕ್ ಆಯಿತು, ಪೈಲೋರಸ್, ಈ ಪೈಲೋರಸ್ ರೀಜನ್ ಏನಾಗಿರುತ್ತೆ, ಸ್ಟಿನೋಸಿಸ್ ಆಗಿರುತ್ತೆ. ಅಂದರೆ ದಿಸ್ ಓಪನಿಂಗ್ ವಿಲ್ ಬಿ ನ್ಯಾರೋ. So because of which there will be delayed passage of food and this will lead to vomiting. Again this will be non-bilious vomiting. ಯಾಕೆ? ಇನ್ನು ಬೈಲ್ ಮಿಕ್ಸ್ ಆಗೋದಲ್ಲಿ ಡುವೋಡೆನಮ್ಮವರೆಗೂ ಫುಡ್ ಹೋಗೇ ಇರಲ್ಲ, ಇಟ್ ವಿಲ್ ಬಿ ಥ್ರೋನ್ ಬ್ಯಾಕ್. ಸೊ ವಾಮಿಟಿಂಗ್ ವಿಲ್ ಬಿ non-bilious above the level of ampulla of Vater and below it will be bilious. Okay. So congenital hypertrophic pyloric stenosis ಅಲ್ಲಿ whatever this pylorus is there, this will be appearing like a gas bubble. Hence single bubble will be there. If there is double bubble, it will be duodenal atresia and annular pancreas. So basically like this, because of annular pancreas, because of the pancreas, duodenum will be appearing like constricted. Aita? That is duodenal atresia. And in case of duodenal atresia, there will be two bubbles. Hence the name double bubble appearance. If there is three bubbles, then it is jejunal atresia. Okay, na? If there are multiple air fluid levels, then it will be usually ileal atresia. So basically, based on abdominal x-ray, we can diagnose these conditions, and in order to differentiate that and put it in a single place, they have given this. Okay. So now coming to the most important topic in pancreas, that is acute pancreatitis. What does this mean? Same like we have discussed alva during bile duct acute cholangitis anta. We can compare it similarly. Cholangitis ಗೆ ಏನೇನು basically two important factors were necessary, that is obstruction or infection. So these were the two most necessary factors leading to acute cholangitis. Similarly here also we can say, if there is an obstruction or if there is an infection, it will lead to inflammation of the pancreas, and that is called as acute pancreatitis. And infection. Okay. So, most common cause for acute pancreatitis is gallstones and then alcohol. Two major causes. So how can gallstone lead to acute pancreatitis? Basically, we have seen whatever the common bile duct is there, that will come and join the pancreatic duct, and then it will open into ampulla of Vater. So this is a common bile duct, and then this will join the major pancreatic duct. There are sphincters, and this will open into second part of the duodenum through major duodenal papillae. So if the common bile duct has some gallstone, and if it obstructs this, whatever the pancreatic enzymes are coming, that will be obstructed, and these are highly degradative. Okay, I mean it causes degradation because it contains enzymes like lipase, which can what happen, it will digest all the pancreatic tissue which is there. Okay na. So basically it is self destructing. ಆಯಿತಾ. ಈ ಲೈಪೇಸು ಈ ಪ್ಯಾಂಕ್ರಿಯಾಟಿಕ್ ಎಂಜೈಮ್ಸ್ ಎಲ್ಲ ಏನಿದೆ, this will digest whatever it gets. So if it reaches the duodenum safely, it will digest the food. If it doesn't, if there is an obstruction because of gallstone, it will start digesting the pancreatic tissue itself. So this will lead to inflammation of the pancreas, which is called as acute pancreatitis. Similarly, there are many other factors which can either lead to infection or cause obstruction, which in turn cause acute pancreatitis. So what are the causes? Blunt trauma, like ಹೊಟ್ಟೆಗೆ ಯಾರೋ ಹೊಡಿತಾರೆ, ಈ ಥರ ಏನೋ blunt trauma to abdomen basically, that will lead to maybe probably obstruction of this pancreatic duct, and that leading to acute pancreatitis. Or while doing ERCP, we'll go through this only alva, endoscope ತಗೊಂಡು we'll reach the major duodenal papillae, and then we'll go for if there is a removal of gallstone or anything. Hence it is the name endoscopic retrograde. We are going from below to above. Okay, so retrograde fashion ಅಲ್ಲಿ ಹೋಗ್ತಾ ಇದೀವಿ. Hence the name endoscopic retrograde cholangiopancreaticography. While doing ERCP, we can damage this pancreatic duct, which in turn can lead to inflammation of the pancreas called ERCP. Other than that, other mechanisms like triglyceridemia, hyperparathyroidism, hypercalcemia, basically calcification ಆಗ್ತಾ ಹೋಗುತ್ತೆ, or there can be cholesterol stone which will lead to obstruction. Then carcinoma of the pancreas is basically a mass is growing from the pancreas which will obstruct the duct of the pancreas. Okay, then cystic fibrosis. All this cystic fibrosis ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, basically secretions will not be cleared easily. Secretions get pulled up because of defective chloride channels. ಆಯಿತಾ. ಸೊ ಸೆಕ್ರೇಷನ್ಸ್ ಏನಾಗುತ್ತೆ, ದೇ ಬಿಕಮ್ ಥಿಕ್ ಆ್ಯಂಡ್ ಮ್ಯೂಕಸ್ ವಿಲ್ ಬಿ ಮೋರ್. ಸೊ ಬಿಕಾಸ್ ಆಫ್ ವಿಚ್ there will be obstruction of the pancreatic duct leading to acute pancreatitis. Okay, so infections cause ಮಾಡೋದಕ್ಕೆ cytomegalovirus, mumps and echovirus, these all lead to infection which in turn lead to inflammation of pancreas called acute pancreatitis. And there are certain drugs which have association with acute pancreatitis. Their mechanism are still under studies. Okay, some major drugs are mercaptopurine, azathioprine, then aminosalicylic acid, tetracyclines, valproate, furosemide, some of the important ones I am saying, and estrogen, then L-asparaginase and acetaminophen. Basically NSAIDs, certain NSAIDs and certain commonly used drugs like estrogen, then furosemide, Lasix and tetracycline, these are also are known to cause acute pancreatitis. So usually these drugs should be avoided if the patient is having gallstones or if he is a chronic alcoholic. Okay, so what is the pathophysiology? What exactly happens in acute pancreatitis is there will be abnormal intrapancreatic activation of these pancreatic enzymes. So basically, if there is obstruction of this pancreatic duct, so whatever the enzymes are coming from pancreas in this duct, this will be abnormally activated inside the pancreas itself. Abnormal intrapancreatic, within the pancreas itself they get activated, and this will cause injury to whatever the duct lining is there, it will cause injury to that duct acini. Okay na? So if there is injury to this duct acini, it will lead to inflammation. If it is mild, it is self limited. Okay, if it is severe, then almost 10 to 30% of the patients die. Okay, so whereas one good news is most common cause is gallstone, and gallstone induced pancreatitis is most curable, or best, it has best prognosis. Okay na? So whatever these pancreatic enzymes are there, they have lipase, just like I have said earlier. It will digest the fat of greater omentum, and this fat is converted to fatty acid and glycerol. So these fatty acids will combine with the calcium, and it forms chalky white deposits called saponification, and this will lead to hypocalcemia. So basically what is happening here, whatever this abnormal activation of pancreatic enzymes have happened, that have caused injury to duct acini, ಅಷ್ಟಕ್ಕೆ ನಿಂತಿಲ್ಲ. What it will do, we know entire abdomen is covered by greater omentum, which is a fat. So this greater omentum has most of the fat, and this lipase enzyme is known to digest fat. So whenever this fat is digested, it will get converted into fatty acid and glycerol. So whatever this fatty acids are there, they will search for calcium now in the body. They'll search for calcium and they'll combine. So basically this mechanism is nothing but soap formation ತರ. ಸೋಪಿಗೂ ಇದೇ ಆಗೋದು, ಫ್ಯಾಟಿ ಆ್ಯಸಿಡ್ ಒಂದು ಫ್ಯಾಟಿ ಆ್ಯಸಿಡ್ ತೊಗೊಳ್ತಾರೆ, ಅದಕ್ಕೊಂದು ಕ್ಯಾಲ್ಸಿಯಂ ಮಿಕ್ಸ್ ಮಾಡಿದರೆ there will be formation of chalky white deposits. That process is called saponification. So there will be deposition of these chalky white deposits throughout the abdomen, and hence there will be usage of calcium too much, and that is called as hypocalcemia. So now patient can have symptoms because of hypocalcemia also, other than pain in the abdomen and all. ಆಯಿತಾ? ಹೆನ್ಸ್ ಇಟ್ ಈಸ್ ಅ ಓವರಾಲ್, ಸಿಸ್ಟಮಿಕ್ ಮ್ಯಾನಿಫೆಸ್ಟೇಷನ್ಸ್ ಆಗಕ್ಕೆ ಶುರು ಆಗುತ್ತೆ. ಬರೀ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ರೀಜನಲ್ಲಿ ಮಾತ್ರ ಲಿಮಿಟ್ ಆಗಿರಲ್ಲ ಈ ಡಿಸೀಸ್. ಓಕೆನಾ? ಸೊ ವಾಟ್ ಈಸ್ ದ ಮೋಸ್ಟ್ ಕಾಮನ್ ಕಾಸ್ ಆಫ್ ಡೆತ್ ಇನ್ ಕೇಸ್ ಆಫ್ ಅಕ್ಯೂಟ್ ಪ್ಯಾಂಕ್ರೈಟೈಟಿಸ್? ವಿತಿನ್ 2 weeks ಆಫ್ ಹಾಸ್ಪಿಟಲೈಸೇಷನ್ ಇದ್ದರೆ ಅದು ಯೂಶಲಿ ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ಮೆಕ್ಯಾನಿಸಮ್ it will be multi-organ dysfunction syndrome, whereas after 2 weeks usually it will because of sepsis. ಆಯಿತಾ? ಇನಿಷಿಯಲಿ ಏನಿರುತ್ತೆ MODS, how can we diagnose the patient is going into MODS ಅಂದರೆ we look for impaired lung function, that is patient will be having difficulty to breathe, breathlessness, ಈ ಥರ ಆಗಕ್ಕೆ ಶುರುವಾಗುತ್ತೆ. ಆವಾಗ ಫಸ್ಟ್ ಬಂದಿದ್ದು ಆ್ಯಕ್ಚುಲಿ ಹೊಟ್ಟೆ ನೋವು ಅಂತ, ಬಟ್ ನಾವ್ he is again complaining of difficulty in breathing or dyspnea, ಏದುಸಿರು ತೊಗೊಳ್ತಿದ್ದಾನೆ ತುಂಬ ಅಂದರೆ we can suspect the patient is going into MODS. ಆಯಿತಾ? ಸೊ ಬೇಸಿಕಲಿ ವಾಟ್ ವಿಲ್ ಬಿ ದ ಕ್ಲಿನಿಕಲ್ ಫೀಚರ್ಸ್? ಜಸ್ಟ್ ಲೈಕ್ ಐ ಸೆಡ್, ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಇಸ್ ಲೊಕೇಟೆಡ್ ಇನ್ ದ C-shaped curve ಆಫ್ ದ duodenum ವಿಚ್ ಇಸ್ ಇನ್ ದ ಎಪಿಗ್ಯಾಸ್ಟ್ರಿಕ್ ರೀಜನ್. ಕರೆಕ್ಟಾ? ಸೊ ಎಪಿಗ್ಯಾಸ್ಟ್ರಿಕ್ ರೀಜನ್ ಅಲ್ಲಿ ಪೇಯ್ನ್ ಬರೋಕ್ಕೆ ಶುರುವಾಗುತ್ತೆ, ಆ್ಯಂಡ್ ದ್ಯಾಟ್ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ರೇಡಿಯೇಟಿಂಗ್ ಟು ಲೆಫ್ಟ್ ಸೈಡ್ ಆಫ್ ದ ಬ್ಯಾಕ್, ಆ್ಯಂಡ್ ಪಾರ್ಷಲಿ ದಿಸ್ ವಿಲ್ ಗೆಟ್ ರಿಲೀವ್ಡ್ ಆನ್ ಸಿಟ್ಟಿಂಗ್ ಆರ್ ಬೆಂಡಿಂಗ್ ಫಾರ್ವರ್ಡ್. ಬೇಸಿಕಲಿ ಟ್ರೈಪಾಡ್ ಪೋಸ್ಚರ್ ಅಂತ ಕರಿತೀವಿ. ಇಫ್ ದ ಪರ್ಸನ್ ಈಸ್ ಲೈಕ್ ದಿಸ್, ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಬೆಂಡಿಂಗ್ ಲೈಕ್ ದಿಸ್. ಆಯಿತಾ? ಬೇಸಿಕಲಿ ಈ ರೀಜನಲ್ಲಿ ಪೇಯ್ನ್ ಇರುತ್ತೆ ಅವನಿಗೆ. ಇಫ್ ಹಿ ಸಿಟ್ಸ್ ಲೈಕ್ ದಿಸ್ ಇನ್ ಟ್ರೈಪಾಡ್ ಪೋಸ್ಚರ್, he will get relief. So that is characteristic. If you go to a ward and the patient is sitting like this with pain in the epigastric region, and he is complaining that left side of the back is also aching along with the pain in the abdomen or in the epigastric region, and if he is sitting in a tripod position, and if he is a chronic alcoholic, you can easily suspect it is a case of acute pancreatitis. ಗೊತ್ತಾಯ್ತಾ? ನಾನು ಇಲ್ಲೇ ಒಂದು ಸಿನಾರಿಯೋ ಕೊಟ್ಟೆ. ಸಪೋಸ್ here is a 40-year-old male who is a alcoholic, complaints of pain in epigastric region, radiates to left side of the back, and he also gives history of relief in pain on bending forward. So this is a classical picture of acute pancreatitis. ಕ್ಲಿನಿಕಲಿನೇ ಡಯಾಗ್ನೋಸ್ ಮಾಡ್ಬೋದು ಅಕ್ಯೂಟ್ ಪ್ಯಾಂಕ್ರೈಟೈಟಿಸ್ ಅಂತ. ಓಕೆ, ಕ್ಲಿನಿಕಲಿ ಓಕೆ, ನಾನು ಇವಾಗ ಸಸ್ಪೆಕ್ಟ್ ಮಾಡ್ತಿದ್ದೀನಿ ಇವನಿಗೆ ಅಕ್ಯೂಟ್ ಪ್ಯಾಂಕ್ರೈಟೈಟಿಸ್ ಇರ್ಬೋದಂತ. ಹೌ ವಿಲ್ ವಿ ಕನ್ಫರ್ಮ್? ವಾಟ್ ಬ್ಲಡ್ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ಸ್ ವಿಲ್ ವಿ ಡೂ, ಆರ್ ವಾಟ್ ಆರ್ ದ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ಸ್ ವಿಲ್ ಡೂ ಯೂಶಲಿ? ಆಯಿತಾ? ಸೊ ವಿಲ್ ಗೋ ಫಾರ್ ಎರೆಕ್ಟ್ ಅಬ್ಡಮೆನ್ ಎಕ್ಸ್ರೇ. ಆಯಿತಾ. ಇನ್ ಕೇಸ್ ಆಫ್ ಪ್ಯಾರಲೈಟಿಕ್ ಐಲಿಯಸ್ ಏನಾದರೂ ಆಗಿದ್ದರೆ, ಪ್ಯಾರಲೈಟಿಕ್ ಐಲಿಯಸ್ ಅಂದ್ರೇನು, ವಿ ಹ್ಯಾವ್ ಡಿಸ್ಕಸ್ಡ್ ವೈಲ್ ಡೂಯಿಂಗ್ ಗಾಲ್ ಬ್ಲಾಡರ್. ಸೊ ಬೇಸಿಕಲಿ ದೇರ್ ಈಸ್ ಅ ಗಾಲ್ ಸ್ಟೋನ್ which has reached the intestine, usually terminal parts of the ileum also, where the intestine is narrow, and it will go and whatever the gallstone is there, that will go into the intestine and will cause obstruction or will block the intestinal opening, because of which there will be paralytic ileus. There will be ileum, I mean terminal ileum alva, ileum alli paralysis ಆದಂಗೆ. So paralytic ileus. Okay, na? In that case, what will be there? Since there is an obstruction, there will be nausea, and whatever the food has been consumed will be thrown out as vomiting, and there will be abdominal distension. So if the pancreatitis is because of gallstone and not alcohol, and if this gallstone has reached ileum after damaging the pancreas, if it has reached ileum, then along with acute pancreatitis, he can have paralytic ileus features also. So if he has a paralytic ileus and you get an erect abdomen x-ray, you can see a gasless abdomen, a ground glass appearance, or a colon cutoff sign. Andre illivargu colon we are seeing transverse colon. After this, it is appearing like there is no colon only. Usually colon will be having gas and it will be appearing like this black. But illivargu colon ittu, idadmele iddakidange colon cut agide. That is called as colon cutoff sign. Okay na? So that can be seen in case of paralytic ileus. Other than this, there can be hemorrhage. Hemorrhage, bleeding ಆಗಕ್ಕೆ ಶುರು ಆಗುತ್ತೆ ಈ ಕೇಸಲ್ಲಿ. acute pancreatitis, basically it is a destructive mechanism. Whatever the pancreatic enzymes are there, they are destroying the pancreas, and because of that, whatever the blood vessels are there, they will start bleeding. And because of that, if this ecchymosis is seen around umbilicus like this, ಎಪಿಗ್ಯಾಸ್ಟ್ರಿಕ್ ರೀಜನಲ್ಲೇ ಇರೋದು ಪ್ಯಾಂಕ್ರಿಯಾಸು, ಆ ರೀಜನಲ್ಲೇ ಕಾಣಿಸ್ತಿದೆ ಅಂದರೆ ಕಲನ್ಸ್ ಸೈನ್ ಅಂತ ಕರಿತೀವಿ ಅದನ್ನು. ಸೊ ಬೇಸಿಕಲಿ ದಿಸ್ ಈಸ್ ಅ ಸೈನ್ ಆಫ್ ಇಂಟರ್ನಲ್ ಬ್ಲೀಡಿಂಗ್, ಒಳಗಡೆ ಬ್ಲೀಡಿಂಗ್ ಆಗ್ತಿದೆ ನೋಡು ಅಂತ ನಮ್ಮ ಬಾಡಿ ನಮಗೆ ಈ ಸೈನ್ ಮೂಲಕ ಹೇಳ್ತಾ ಇದೆ. ಓಕೆನಾ. ಸೊ ಇಫ್ ದೆರ್ ಈಸ್ ಎಕೈಮೋಸಿಸ್ ಅರೌಂಡ್ ಫ್ಲ್ಯಾಂಕ್, ಬಿಕಾಸ್ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಇಸ್ ಅ ರೆಟ್ರೋಪೆರಿಟೋನಿಯಲ್ ಆರ್ಗನ್, ಇಟ್ ಕ್ಯಾನ್ ಶೋ ಇನ್ ದ ಎಪಿಗ್ಯಾಸ್ಟ್ರಿಕ್ ರೀಜನ್ ಆರ್ ದ ಬ್ಲೀಡಿಂಗ್ ಕ್ಯಾನ್ ಬಿ ಇನ್ ದ ಫ್ಲ್ಯಾಂಕ್, ಬಿಕಾಸ್ pancreas retroperitoneal organ ಹಿಂದಕ್ಕೆ ಅಟ್ಯಾಚ್ ಆಗಿದೆ. ಜಸ್ಟ್ ಲೈಕ್ ದ ಪೇನ್ ರೇಡಿಯೇಟ್ಸ್ ಟು ಲೆಫ್ಟ್ ಸೈಡ್ ಆಫ್ ದ ಬ್ಯಾಕ್, ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಸೀನ್ ಇನ್ ದ ಲೆಫ್ಟ್ ಆರ್ ರೈಟ್ ಸೈಡ್ ಆಫ್ ದ ಫ್ಲ್ಯಾಂಕ್. ಸೊ ದಿಸ್ ಸೈನ್ ಇಸ್ ಕಾಲ್ಡ್ ಅಸ್ ಗ್ರೇ ಟರ್ನರ್ ಸೈನ್. ಅದೇ ಥರ ಇಫ್ ದ ಎಕೈಮೋಸಿಸ್ ಈಸ್ ಇನ್ ದ ಇಂಗ್ವೈನಲ್ ರೀಜನ್ಗೆ ಯಾಕೆ? ಬಿಕಾಸ್ ಇನ್ ದ ಅಬ್ಡಮನ್ ದೆರ್ ಈಸ್ ನೋ ಸ್ಪೆಸಿಫಿಕ್ ಸೈಟ್ ವೇರ್ ಲೈಕ್ ತಡೆಯೋಂಥ ಬ್ಲೀಡಿಂಗ್ ತಡೆಯೋಂಥದ್ದು ಯಾವುದೂ ಇಲ್ಲ. ಸೀದಾ ಎಲ್ಲಿಗೆ ಹೋಗುತ್ತೆ? ಇಟ್ ಈಸ್ ಕಂಟಿನ್ಯೂಸ್, ಅಂದರೆ ಎಕ್ಸ್ಟರ್ನಲ್ ಏನಂತಾರೆ ಆಂಟೀರಿಯರ್ ಅಬ್ಡಾಮಿನಲ್ ವಾಲ್ ಈಸ್ ಕಂಟಿನ್ಯೂಸ್ ಟಿಲ್ ಇಂಗ್ವೈನಲ್ ರೀಜನ್. ಸೊ ಇಫ್ ದೆರ್ ಈಸ್ ಬ್ಲೀಡಿಂಗ್ ಹಿಯರ್ ಇನ್ ದ ಎಪಿಗ್ಯಾಸ್ಟ್ರಿಕ್ ರೀಜನ್ ಆ್ಯಂಡ್ ಇಫ್ ದ ಪೇಷಂಟ್ ಈಸ್ ಸ್ಟ್ಯಾಂಡಿಂಗ್ ಅಂದ್ಕೊಳ್ಳಿ, ಬಿಕಾಸ್ ಆಫ್ ಗ್ರಾವಿಟಿ ವಾಟ್ ಎವರ್ ದ bleeding is there, that will go and settle in the inguinal region, and that is called as Fox sign. So basically we can see hemorrhage in three regions. It can be epigastric region, it can be in the flank, or it can be in the inguinal region, and hence the name Gray Turner, Cullen, Gray Turner and Fox sign. Okay na? So how will we diagnose? Investigation of choice is contrast enhanced CT scan, but usually CECT will be done after 72 hours, because whatever the complications are there we can easily identify. Immediate ಆಗಿ ಅವನು ಇವಾಗಿನ್ನು ಪೇನ್ ಅಂತ ಬಂದ ಅಂದರೆ immediately he won't be having hemorrhage, immediately there will be not much changes in the pancreas, so that we can catch the acute pancreatitis. If after 72 hours there will be short we can diagnose it as acute pancreatitis, hence it is usually reserved. But within 72 hours ಹಂಗಾರೆ ಅವ್ನು ಬಂದು 3 ದಿನ ಆಗೋವರೆಗೂ ಏನು ಮಾಡೋದೇ ಇಲ್ವಾ ಇನ್ವೆಸ್ಟಿಗೇಷನ್? ಸೊ ಕಾಂಟ್ ವಿ ಕನ್ಫರ್ಮ್ ಅದರ್ ದ್ಯಾನ್ CECT ಅಂದರೆ ವಿ ಕ್ಯಾನ್ ಡೂ ಇಟ್. ವಿ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ ಬ್ಲಡ್ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ಸ್ ಲೈಕ್ ಸೀರಮ್ ಅಮೈಲೇಸ್ ಆ್ಯಂಡ್ ಸೀರಮ್ ಲೈಪೇಸ್. ಸೀರಮ್ ಅಮೈಲೇಸ್ ಆ್ಯಂಡ್ ಸೀರಮ್ ಲೈಪೇಸ್, ಓಕೆನಾ? ಯೂಶಲಿ ಸೀರಮ್ ಲೈಪೇಸ್ ಅವಾಗಲಿಂದ ಹೇಳ್ತಿದ್ದೀನಿ, ದಿಸ್ ವಿಲ್ ಬಿ ಎಲಿವೇಟೆಡ್ ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಮೋರ್ ಸ್ಪೆಸಿಫಿಕ್ ಫಾರ್ ಅಕ್ಯೂಟ್ ಪ್ಯಾಂಕ್ರೆಟೈಟಿಸ್. ಆಯಿತಾ? ಅದರ್ ದೆನ್ ದಟ್ ಸೀರಮ್ ಅಮೈಲೇಸ್ ವಿಲ್ ಆಲ್ಸೋ ಬಿ ಎಲಿವೇಟೆಡ್. But this is more specific. If serum lipase has raised, then it is sure that it is acute pancreatitis. Aita? Other than that, we can go for CECT. CECT is not only used in case of acute pancreatitis, but it can also be used in cases of pancreas like pancreatic pseudocyst, pancreatic abscess, pancreatic necrosis and carcinoma of pancreas. Basically, for all these conditions related to pancreas, the investigation of choice is CECT. Similarly, for kidney related also, for and other pathologies also CECT is done. Basically they have covered CECT here. Okay, so we are done with clinical features and diagnosis, and now how will we treat this case? Management is basically, since the patient is going into multi-organ dysfunction syndrome, MODS, basically ಅದರ ಜೊತೆಗೆ he will stop eating anything because of pain abdomen. So in order to keep him hydrated and resuscitated, we'll go for fluid resuscitation. First fluids ಹಾಕ್ತೀವಿ ಆಯಿತಾ. ಆ್ಯಂಡ್ ಫ್ಲೂಯಿಡ್ ಆಫ್ ಚಾಯ್ಸ್ ಇಸ್ ರಿಂಗರ್ ಲ್ಯಾಕ್ಟೇಟ್, ಎಲೆಕ್ಟ್ರೋಲೈಟ್ಸ್ ಎಲ್ಲ ಇರಲಿ ಅಂತ ರಿಂಗರ್ ಲ್ಯಾಕ್ಟೇಟ್. ಅದಲ್ಲದೆ ಬಿಕಾಸ್ he can go for MODS and he will develop respiratory distress ಆಯಿತಾ. ಹೆನ್ಸ್ ವಿಲ್ ಗೋ ಫಾರ್ ಆಕ್ಸಿಜನ್ ಸಪ್ಲಿಮೆಂಟೇಷನ್, O2 ಕೊಡ್ತೀವಿ ಅವನಿಗೆ. ಅದಲ್ಲದೆ ಪೇಯ್ನ್ ಇದೆ ತುಂಬ, ಸೊ ಪೇಯ್ನ್ ರಿಲೀವ್ ಮಾಡೋಕ್ಕೆ ಅನಾಲ್ಜೆಸಿಕ್ಸ್ ಕೊಡಬೇಕು. NSAIDs ಲೈಕ್ ಮೆಟಾಮಿಝೋಲ್ ಆರ್ ಒಪಿಯಾಯ್ಡ್ಸ್ ಲೈಕ್, ಅಂದರೆ ತುಂಬ ಹೈ ಲೆವೆಲ್ ಪೇಯ್ನ್ ಇರುತ್ತೆ, ಹೆನ್ಸ್ ವಿ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ ಒಪಿಯಾಯ್ಡ್ಸ್ ಲೈಕ್ ಬುಪ್ರೆನಾರ್ಫಿನ್ ಆಲ್ಸೋ. ಓಕೆ, other than that we should continue internal nutrition rather than giving total parenteral nutrition. And if the patient is already in shock, on BP already 60/80 ಇದೆ ಅಥವಾ 80/60 ಇದೆ, if he is unable to consume orally, and if the acute pancreatitis is too severe, only then we should go for total parenteral nutrition, otherwise we have to feed him orally. Okay, or via nasogastric tube, NG tube ಹಾಕ್ಬಿಟ್ಟು we can feed him, Ryle's tube basically. ಆಯಿತು. ಸೊ this is the management. This is all about acute pancreatitis. Basically we have discussed acute pancreatitis under different headings. One is risk factors or causes. Most common cause is gallstone, and second cause is alcohol. Other than that, there are many other causes we have discussed which can lead to obstruction or infection. Viral infections ಆದರೆ cytomegalovirus, HBV, HCV ಇದೆಲ್ಲ ನೋಡಿದ್ವಿ. Other than that, there can be carcinoma of the pancreas or ERCP, blunt trauma, then cystic fibrosis. Then drugs, there are certain drugs like tetracyclines, amino salicylic acid. So this was the risk factors. After that, we discussed about pathophysiology. Basically, the enzymes of the pancreas will get activated within the duct and it will start destroying the duct acini, thereby causing inflammation. ಇದಾದಮೇಲೆ ಫ್ಯಾಟ್, ಗ್ರೇಟರ್ ಮೊಮೆಂಟಮ್ ಅಲ್ಲಿರೋ ಫ್ಯಾಟ್ ವಿಲ್ ಗೆಟ್ ಡೈಜೆಸ್ಟೆಡ್ ಆ್ಯಂಡ್ ದಟ್ ವಿಲ್ ಫಾರ್ಮ್ ಫ್ಯಾಟಿ ಆಸಿಡ್ ಆ್ಯಂಡ್ ಗ್ಲಿಸರಾಲ್. ದಟ್ ವಿಲ್ ಲೀಡ್ ಟು consumption of calcium, forming chalky white deposits called saponification, and that will lead to hypocalcemia also. Other than that, what are the clinical features? Pain in the epigastric region radiating to the left side of the back, and the patient will be usually sitting in a tripod position or will be bending forward. Aita. Other than that, if the gallstone is the main cause and if it is obstructing the ileum, then it will lead to paralytic ileus, and we can see the following features on the X-ray of the abdomen. Other than that, it can lead to hemorrhage, which can be seen as Cullen sign or Great Turner sign or Fox sign. Investigation of choice is CECT, but usually it will be done after 72 hours. So until then, we can go for blood tests like serum amylase and serum lipase, and if they are elevated, and if serum lipase is elevated, it is most specific, and we can diagnose it as acute pancreatitis and start with the management, which is fluid resuscitation, oxygen supplementation, and analgesics in order to relieve pain. After that, if still, we have to continue enteral nutrition. If the patient is in shock or if there is severe acute pancreatitis, only then we have to go for total parenteral nutrition. Okay, so ivaga I said this, if there is severe acute pancreatitis, only then go for TPNL. How will we assess which is normal pancreatitis or which is mild acute pancreatitis and which is severe acute pancreatitis? ನನಗೆ ಹೆಂಗೆ ಗೊತ್ತಾಗಬೇಕು which is mild, which is severe ಅಂತ ಕೇಳಿದರೆ, there are certain scoring systems which have been proposed in order to assess this mild or severe acute pancreatitis. Along with that, if it is treatable or if it is curable or not ಅನ್ನೋದನ್ನು ಅಸೆಸ್ ಮಾಡೋಕ್ಕೆ there are certain scoring systems. It is Ranson's scoring, modified Glasgow score, BISAP score, QSOFA, APACE score or CT severity index. ಈ ಥರ ಸುಮಾರು ಸ್ಕೋರ್ಸ್ ಇದೆ ಆಯಿತಾ. ದಿಸ್ ವಿಲ್ ಬಿ ಬೇಸಿಕಲಿ ಆಸ್ಕ್ಡ್ ಫಾರ್ ಅಸ್ MBBS ಸ್ಟೂಡೆಂಟ್ಸ್. ನಿಮ್ಗೆ ಜಸ್ಟ್ ಈ ಥರ ಗೊತ್ತಿರಲಿ, ಇನ್ ಆರ್ಡರ್ ಟು ಅಸೆಸ್ ದಿಸ್ ವಿಲ್ ಯೂಸ್ ಸೋ ಮೆನಿ ಸ್ಕೋರಿಂಗ್ ಸಿಸ್ಟಮ್ಸ್. ಬೇಸಿಕಲಿ ಏನೇನು ಯೂಸ್ ಮಾಡ್ತಾರೆ ಅದರಲ್ಲಿ ಅಂದರೆ, ಏಜು, ಡಬ್ಲ್ಯೂ ಬಿ ಸಿ ಕೌಂಟು, ಶುಗರ್ ಲೆವೆಲ್ಸು, ಎ ಎಸ್ ಟಿ ಎ ಎಲ್ ಟಿ ಲೆವೆಲ್ಸು, ಈ ಥರ. ಓಕೆನಾ. ದಿಸ್ ವಾಸ್ ಅಬೌಟ್ ರ್ಯಾನ್ಸಮ್ ಸ್ಕೋರ್. ಬಿಸಾಪ್ ಸ್ಕೋರ್ ಅಂದರೆ ಬೆಡ್ ಸೈಡ್ ಇಂಡೆಕ್ಸ್ ಫಾರ್ ಸಿವಿಯಾರಿಟಿ ಆಫ್ ಅಕ್ಯೂಟ್ ಪ್ಯಾಂಕ್ರೈಟೈಟಿಸ್. ಇದರಲ್ಲಿ ಬಿಸಾಪ್ನೇ ನಿಮೋನಿಕಾಗಿ ಯೂಸ್ ಮಾಡ್ಕೋತೀವಿ. ಬನ್ ಅಂದರೆ ಬ್ಲಡ್ ಯೂರಿಯಾ ನೈಟ್ರೋಜನ್ ಇಫ್ ಇಟ್ ಈಸ್ ಮೋರ್ ದ್ಯಾನ್ 25 ಆ್ಯಂಡ್ ಇಫ್ ದೆರ್ ಈಸ್ ಇಂಪೇರ್ಡ್ ಮೆಂಟಲ್ ಸ್ಟೇಟಸ್ ಆ್ಯಂಡ್ ಇಫ್ ದೆರ್ ಈಸ್ ಸಿಸ್ಟಮಿಕ್ ಇನ್ಫ್ಲಮೇಟರಿ ರೆಸ್ಪಾನ್ಸ್ ಸಿಂಡ್ರೋಮ್ ಅಂದರೆ ಫೀವರ್, ಟೆಂಪರೇಚರ್ ಮೋರ್ ದೆನ್ 38 ಇದೆ, ಹಾರ್ಟ್ ರೇಟ್ ಟೆಕಿಕಾರ್ಡಿಯಾ ಇದೆ, ನನಗೆ ರೆಸ್ಪಿರೇಟರಿ ರೇಟ್ ಟೆಕಿಪ್ನಿಯಾ ಇದೆ, ಅಲಾಂಗ್ ವಿತ್ ದಟ್ ಇನ್ಫೆಕ್ಷನ್ ಇಸ್ ಮೋರ್. ಆಯಿತಾ. ಸೊ ಈ ಕೇಸಲ್ಲಿ there will be a sepsis. Along with that, if the patient is more than 60 years and if he is having pleural effusion, ಸೊ ಇದೇನು ಮಾಡ್ತೀವಿ, ಇದಕ್ಕೆಲ್ಲದಕ್ಕೂ ಒಂದೊಂದು ಸ್ಕೋರ್ ಅಂತ ಕೊಟ್ಕೊಂಡು ಹೋಗ್ತೀವಿ. 1 1 1. ಸೊ ಬೇಸಿಕಲಿ 5, ಮ್ಯಾಕ್ಸಿಮಮ್ ಇಸ್ 5. ಔಟ್ ಆಫ್ 5 ವಿ ವಿಲ್ ಅಸೆಸ್ ನಾವು. ಆಯಿತಾ. ಇಫ್ ದ ಪೇಷಂಟ್ ಈಸ್ ಹ್ಯಾವಿಂಗ್ ಸ್ಕೋರ್ ಆಫ್ ಮೋರ್ ದ್ಯಾನ್ 3, ದೆನ್ ಇಟ್ ಈಸ್ ಸಿವಿಯರ್. ಇಫ್ ಇಟ್ ಈಸ್ 0 to 2, ಇಟ್ ಈಸ್ ಲೆಸ್ ದ್ಯಾನ್ 2% ಮಾರ್ಟಾಲಿಟಿ. ಅಂದರೆ patient will survive ಆರಾಮ್ಸೆ. ಬೇಸಿಕಲಿ you will have to give analgesics well and resuscitate him well and he'll be okay. ಆಯಿತಾ. ಇಫ್ ದ ಸ್ಕೋರ್ ಈಸ್ ಬಿಟ್ವೀನ್ 3 to 5, there will be more than 15% mortality. There is a condition, there is a chance that he'll die. Like out of 100, 15 patients will die. ಆ ಥರ. ಸೊ 15% mortality ಇರುತ್ತೆ. You will have to explain it to the patient attenders. So Q SOFA is basically for sequential organ failure assessment. ನಾನು ಅವಾಗಲಿಂದ ಮಾಡ್ಸ್ ಅಂತ ಹೇಳ್ತಿದ್ನಲ್ಲ, ಮಲ್ಟಿ ಆರ್ಗನ್ ಡಿಸ್ಫಂಕ್ಷನ್ ಸಿಂಡ್ರೋಮ್. ಸೊ ಮಲ್ಟಿ ಆರ್ಗನ್ ಫೇಲ್ಯೂರ್ನ ಹೆಂಗೆ ಅಸೆಸ್ ಮಾಡ್ತೀವಿ? ಇಫ್ ಜಸ್ಟ್ ಅವ್ನ ಪೇಷಂಟ್ ನೋಡಿದ ತಕ್ಷಣ ಗೊತ್ತಾಗುತ್ತೆ. ಇಫ್ ದ ಪೇಷಂಟ್ ಈಸ್ ಹ್ಯಾವಿಂಗ್ ರೆಸ್ಪಿರೇಟರಿ ರೇಟ್ ಮೋರ್ ದ್ಯಾನ್ 22 per minute and we'll measure his BP. If the BP is less than 100 and if he is not in a proper mental status, then we'll give the score 0 1 2. ಆಯಿತಾ. ಇಫ್ he is having more than 2, 1 1 1 ಅಂತ ತಗೊಳ್ಳಿ. ಸೊ maximum score is 3. If he is 0, he is okay. ಆಯಿತಾ. there is no organ dysfunction, so less than 1% mortality. If it is 1, any 1, then 2 to 3% mortality ಇರುತ್ತೆ. If it is more than 2, then there is 10% mortality. So hence severity assess ಮಾಡೋಕ್ಕೆ we can use this. ಓಕೆ. ಸಿಮಿಲರ್ಲಿ ಅದೇ ಥರ ಇನ್ನು ಎಲ್ಲ ಸ್ಕೋರ್ಸ್ ಇವೆ. ಸೊ we can go on discussing about it. ಸಾಕು ಇಷ್ಟು. ಓಕೆನಾ. ಸೊ this is how we will assess. One person will use whatever the score he is comfortable with. Okay. So what are the complications? What will happen if we don't diagnose acute pancreatitis and if we don't treat it well? Okay. What are the local complications and what are the systemic complications that can happen? Acute ಅಂದರೆ less than 4 weeks. ಸೊ ಏನೇನಾಗ್ಬೋದು? acute pancreatic fluid collection ಆಗೋಕ್ಕೆ ಶುರುವಾಗುತ್ತೆ. and this fluid collection will in turn lead to necrosis. ಆಯಿತಾ. if the patient is alive after 4 weeks, it turns chronic and there will be definite wall formation around these pancreatic enzymes. Whatever the tissue is getting degraded, ಅದರ ಸುತ್ತ ಒಂದು ಡಿಫೈನ್ಡ್ ಕಲೆಕ್ಷನ್ ಆಗುತ್ತೆ. ಇವಾಗ ಬೇಸಿಕಲಿ ಇಫ್ ದಿಸ್ ಈಸ್ ಪ್ಯಾಂಕ್ರಿಯಾಸ್, ಕ್ರಾನಿಕ್ ಆದರೆ ಈ ಥರ ಆಗೋಕ್ಕೆ ಶುರುವಾಗುತ್ತೆ. there is a defined wall. So this pancreas, this part of the pancreas which is getting inflamed, acute pancreatitis ಆಗಿದೆ. This has been more than a 4 week and there is a formation of definite wall. Now this becomes chronic pancreatitis. ಆಯಿತಾ. So whatever this fluid is getting collected, this appears like a cyst now and hence the name pseudocyst. This is not actually a cyst, but because of the collections of inflammation products, it is appearing like a cyst and hence the name pseudocyst. ಆಯಿತಾ. So this is a pseudocyst. This is a complication of acute pancreatitis. And then world of necrosis. World of necrosis is basically this will start getting necrosed. That is world of necrosis. So these are the local complications. So acute pancreatic fluid collection usually will resolve spontaneously. In some cases after 4 weeks it will develop into pancreatic pseudocyst. Aita. This pseudocyst will get infected and that can lead to formation of an abscess and thus pus collection will be there in the peripancreatic region. What is the treatment for this pancreatic abscess? We'll do USG or CT guided percutaneous aspiration and for infection we'll treat with antibiotics. So ಏನು ಪಸ್ ಅಕ್ಯುಮುಲೇಟ್ ಆಗಿದೆ ಅದನ್ನು ತೆಗಿಬೇಕು ಥ್ರೂ percutaneous aspiration and for infection we'll give antibiotics. So if it goes for necrosis, then whatever the non-viable pancreatic tissue is there, or the peripancreatic fat will be there, it is a sterile condition. There will be no infection. Pus case agalla, just necrosis agi alle udkodutte. And this most common complication is infection. Aita, most common organism usually ಬಾಡಿಯಲ್ಲಿ ಇರೋದು ಯಾವುದು E. coli. So what should we do for management? We should do repeated necrosectomy. ಅಂದರೆ ಯಾವ part of the pancreas has undergone necrosis, we should remove it. And then we should surgically debride with ongoing lavage. So this was a treatment for pancreatic necrosis. Pseudocyst formation ಆದರೆ ಏನು ಮಾಡಬೇಕು? Cystic collection ಆಗಿದೆ. It is a false cyst, hence the name pseudocyst. So ಇದಕ್ಕೆ ಏನು ಮಾಡಬೇಕು? Most common cause is usually alcohol, and it is most commonly seen in lesser sac. Okay. Pseudocyst is seen in both the cases, like acute pancreatitis allu irutte, chronic pancreatitis allu irutte. Usually in acute pancreatitis it will be singular and large, and it will be usually outside of the pancreas, extra pancreatic. Chronic alladre there will be multiple small and intrapancreatic. Clinical features ಏನಿರುತ್ತೆ in case of pancreatic pseudocyst? So yeah, this is a separate topic. Like acute pancreatitis na discuss ಮಾಡಿದ್ವಿ, ಅದಲ್ಲದೆ pancreatic pseudocyst ಬಗ್ಗೆ they can ask separate question. Hence this should be studied like a separate disease. Though it is a complication of acute pancreatitis, it can be seen in both acute or chronic pancreatitis. And ಅದರಲ್ಲಿ ಡಿಫ್ರೆನ್ಸ್ ಹೇಳಿದೆ, ಇದರಲ್ಲಿ ಯೂಶಲಿ ಸಿಂಗಲ್ ಆ್ಯಂಡ್ ಲಾರ್ಜ್ ಇರುತ್ತೆ, ಇದರಲ್ಲಿ ಮಲ್ಟಿಪಲ್ ಸ್ಮಾಲ್ ಇರುತ್ತೆ. ಆಯಿತಾ? ಸೊ ಬೇಸಿಕಲಿ ದ ಪೇಷಂಟ್ ಎಪಿಗ್ಯಾಸ್ಟ್ರಿಕ್ ರೀಜನಲ್ಲಿ ಪೇಯ್ನ್ ಬರ್ತಿದೆ, ಅವ್ನಿಗೆ ಅಕ್ಯೂಟ್ ಪ್ಯಾಂಕ್ರೆಟೈಟಿಸ್ ಶುರುವಾಗಿದೆ, ಬಟ್ ಸ್ಟಿಲ್ ಹಿ ಹ್ಯಾಸ್ ನಾಟ್ ಕಮ್ ಟು ಯು, ಹಿ ಹ್ಯಾಸ್ ಇಗ್ನೋರ್ಡ್ ದ ಪೇಯ್ನ್. ಆಯಿತಾ? ಹಿ ಹ್ಯಾಸ್ ಟೇಕನ್ ಸಮ್ ಪ್ಯಾರಾಸಿಟಮಾಲ್ ಆರ್ ಸಮ್ ಡೈಕ್ಲೋಫೆನಾಕ್ ಆ್ಯಂಡ್ ಹಿ ಹ್ಯಾಸ್ treated himself with NSAIDs, and he has not come to you, and then the acute pancreatitis whichever was going on inside him has progressed, and it has now led to a pancreatic pseudocyst. So now what will be the clinical features he will be having? In most patients pseudocyst will be small, so it is usually asymptomatic. If there appears symptoms, then it will be most commonly it will be abdominal pain obviously, and then there will be vomiting because it is non-bilious usually. Because ನಾನು ಹೇಳ್ದಂಗೆ pancreas is it will be draining before ample of water, so vomiting will be non-bilious and it will be containing undigested food. So ಇದಾದಮೇಲೆ ಏನಾಗುತ್ತೆ, if this pseudocyst persists like that only, there will be no problem. If it goes for complications like infection or it bursts out and it leads to hemorrhage, then there will be ಮಾಡ್ಸು ಈ ಥರ, ಮತ್ತು ಅಗೇನ್ ದೇರ್ ವಿಲ್ ಬಿ ಕಾಂಪ್ಲಿಕೇಶನ್ ಆ್ಯಂಡ್ ಇಟ್ ಕ್ಯಾನ್ ಲೀಡ್ ಟು ಮಾರ್ಟಾಲಿಟಿ ಆಲ್ಸೋ. ಸೊ ಡಯಾಗ್ನೋಸಿಸ್ ಹೇಗೆ ಮಾಡ್ತೀವಿ? CECT. ಓಕೆ. ಸೊ ಮ್ಯಾನೇಜ್ಮೆಂಟ್, ಕನ್ಸರ್ವೇಟಿವ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್, ಮೋಸ್ಟ್ ಆಫ್ ದ ಸ್ಯೂಡೋಸಿಸ್ಟ್ ವಿಲ್ ರಿಸಾಲ್ವ್ ಸ್ಪಾಂಟೇನಿಯಸ್ಲಿ. ನಾನು ಹೇಳ್ದಂಗೆ ಸ್ಯೂಡೋಸಿಸ್ಟ್ ಹಾಗೆ ಉಳ್ಕೊಂಡು ವಿ ಹ್ಯಾವ್ ಡಯಾಗ್ನೋಸ್, ಆ್ಯಂಡ್ ಇಫ್ ಇಟ್ ಈಸ್ ಜಸ್ಟ್ ಅ ಸ್ಯೂಡೋಸಿಸ್ಟ್ ವಿಲ್ ಗೋ ಫಾರ್ ಕನ್ಸರ್ವೇಟಿವ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್, ವಿಲ್ ವೇಟ್ ಆ್ಯಂಡ್ ವಾಚ್. If the duration is more than 6 weeks and the pseudocyst hasn't resolved, or if the size of the pseudocyst is more than 6 centimeter, then we will have to go for surgery. ಏನು ಸರ್ಜರಿ ಮಾಡ್ತೀವಿ? ವಿಲ್ ಗೋ ಫಾರ್ ಸಿಸ್ಟೋಜೆಜುನಾಸ್ಟಮಿ. ಆಯಿತಾ? ಸಿಸ್ಟ್ ತೆಗೆದು ಜೆಜುನಮಿ ಕನೆಕ್ಟ್ ಮಾಡೋದು. ದೆನ್ whatever the duct is there, because of the obstruction of the duct there is formation of this cyst ಅಲ್ವಾ. ಸೊ ವಿಲ್ ಕನೆಕ್ಟ್ ದ ಡಕ್ಟ್ ಟು ಜೆಜುನಮ್. ಸೊ ಡ್ಯೂಯೋಡೆನಮ್ ಒಳಗೆ ಡ್ರೈನ್ ಆಗೋದ್ರ ಬದಲು ಜೆಜುನಮಿಗೆ ಡ್ರೈನ್ ಆಗುತ್ತೆ ಇವಾಗ ಅಷ್ಟೇ, ಪ್ಯಾಂಕ್ರೆಟಿಕ್ ಜ್ಯೂಸ್ ಎಲ್ಲ. ಓಕೆ. ಅದ್ರ ಬದಲು ವಿ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ ಸಿಸ್ಟೋಗ್ಯಾಸ್ಟ್ರಾಸ್ಟಮಿ, ಅಂದರೆ ವಿ ಕ್ಯಾನ್ ಕನೆಕ್ಟ್ ದಿಸ್ ಪ್ಯಾಂಕ್ರಿಯಾಟಿಕ್ ಡಕ್ಟ್ ಟು ಸ್ಟಮಕ್, ಸಿಸ್ಟೋಗ್ಯಾಸ್ಟ್ರಾಸ್ಟಮಿ ಆರ್ ಸಿಸ್ಟೋಡ್ಯೂಯೋಡೆನಾಸ್ಟಮಿ. ಡ್ಯೂಯೋಡೆನಮ್ಮಲ್ಲೇ ಕ್ಲಿಯರ್ ಮಾಡ್ಬೋದು. ಸೊ ಬೇಸಿಕಲಿ ವಿ ಕ್ಯಾನ್ ಕನೆಕ್ಟ್ ದ ಪ್ಯಾಂಕ್ರಿಯಾಟಿಕ್ ಡಕ್ಟ್ ಟು stomach or duodenum or jejunum. ಸೊ ಇಲ್ಲಿ ಸಿಸ್ಟ್ ಏನಕ್ಕೆ ಫಾರ್ಮೇಷನ್ ಆಗ್ತಿದೆ ಅಂತ ಗೊತ್ತಾಗಿದ್ರೆ ಆಯಿತು, ಕಂಡೀಷನ್ ಅಷ್ಟೇ. ಸೊ ಇವಾಗ ಬೇಸಿಕಲಿ ದಿಸ್ ಇಸ್ ಡಕ್ಟ್ ಅಂತ ಅಂದ್ಕೊಳ್ಳಿ. ಓಕೆ. ಸೊ ದಿಸ್ ಇಸ್ ಅ ಸಿಸ್ಟ್. ಸೊ ವಾಟ್ ಎವರ್ ದ secretions are coming from the duct, this is accumulating here in the form of a fluid. ಓಕೆನಾ? ಸೊ ನಾವು ಇವಾಗ ಟ್ರೀಟ್ಮೆಂಟ್ ಏನು ಮಾಡ್ತೀವಿ? ವಿ ವಿಲ್ ಜಸ್ಟ್ ಕನೆಕ್ಟ್ ದಿಸ್ cyst to stomach. ಸೊ ಇಲ್ಲಿ ಇದರಿಂದ ಬಂದಿದ್ದ ಸೆಕ್ರೇಷನ್ಸ್ ಎಲ್ಲ ಈ ಸಿಸ್ಟಿಂದ ಇಟ್ ವಿಲ್ ಗೋ ಇಂಟು ಸ್ಟಮಕ್ ಅಂಡ್ ಇಟ್ ವಿಲ್ ಡ್ರೈನ್ ಇಂಟು ಇಂಟೆಸ್ಟೈನ್ ಓನ್ಲಿ. ಆಯಿತಾ? ದಿಸ್ ಇಸ್ ಸಿಸ್ಟೋ ಗ್ಯಾಸ್ಟ್ರಾಸ್ಟಮಿ. ಅದೇ ಥರ ವಿ ಕ್ಯಾನ್ ಕನೆಕ್ಟ್ ಇಟ್ ಟು ಡುಯೋಡೆನಮ್ ಆರ್ ವಿ ಕ್ಯಾನ್ ಕನೆಕ್ಟ್ ಇಟ್ ಟು ಜೆಜುನಮ್. ಹೆನ್ಸ್ ದ ಪ್ರೊಸೀಜರ್: ಸಿಸ್ಟೋ ಗ್ಯಾಸ್ಟ್ರಾಸ್ಟಮಿ, ಸಿಸ್ಟೋ ಜೆಜುನಾಸ್ಟಮಿ, ಸಿಸ್ಟೋ ಡುಯೋಡೆನಾಸ್ಟಮಿ. ದಿಸ್ ಇಸ್ ದ ಟ್ರೀಟ್ಮೆಂಟ್. ಡಿಸಡ್ವಾಂಟೇಜ್ ಏನು, ಸ್ಟೊಮಕ್ಕಿಗಾದರೆ ಅಗೇನ್ಸ್ಟ್ ಗ್ರಾವಿಟಿ ಹೆಂಗೆ ಕೆಳಗೆ ಹೋಗಬೇಕು, ಬಟ್ ವಿ ಆರ್ ಟ್ರೈಂಗ್ ಟು ಡ್ರೈನ್ ಇಟ್ ಅಗೇನ್ಸ್ಟ್ ಗ್ರಾವಿಟಿ. ಅಗೇನ್ ಸಿನ್ಸ್ ದ ಡ್ರೈನೇಜ್ ಈಸ್ ಅಗೇನ್ಸ್ಟ್ ದ ಗ್ರಾವಿಟಿ, ಫುಡ್ ಪಾರ್ಟಿಕಲ್ಸ್ ಮೇ ಎಂಟರ್ ದ ಸೂಡೋಸಿಸ್ಟ್ ಆ್ಯಂಡ್ ಕಾಸ್ ಇನ್ಫೆಕ್ಷನ್. ಅಂದರೆ ಇಲ್ಲಿ ಒಂದು ಪೋರ್ಟ್ ಕ್ರಿಯೇಟ್ ಮಾಡಿದರೆ ಇನ್ಸ್ಟೆಡ್ ಆಫ್ ದಿಸ್ ಫ್ಲೂಯಿಡ್ ಗೋಯಿಂಗ್ ಇನ್ ಟು ಸ್ಟೊಮಕ್, ವಾಟ್ ಎವರ್ ದ ಫುಡ್ ವಿ ಹ್ಯಾವ್ ಕನ್ಸ್ಯೂಮ್ಡ್ ದ್ಯಾಟ್ ಮೈಟ್ ಕಮ್ ಇನ್ ಟು pseudocyst and that can lead to infection, and that is called as sump syndrome. Okay, we leave that. So yeah, this was about this was about pseudocyst of pancreas. ಆಯಿತಾ, ಅದ್ರ ಬಗ್ಗೆ ಇನ್ನು ಡೀಟೇಲಾಗಿ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡಿದ್ದಾರೆ. ಸಿಸ್ಟೋ ಜೆಜುನೋಸ್ಟಮಿ ಹಿಂಗೆ ಮಾಡ್ತಾರೆ, ಸಿಸ್ಟೋ ಡುವೋಡೆನೋಸ್ಟಮಿ ಹಿಂಗೆ ಅಂತ. ದಟ್ ಆ್ಯಂಡ್ ಆಲ್ ಈಸ್ ನಾಟ್ ನೆಸೆಸರಿ ಫಾರ್ ಯು ಗೈಸ್. ಓಕೆ, ಸೊ ಕ್ರೋನಿಕ್ ಪ್ಯಾಂಕ್ರಿಯಾಟೈಟಿಸ್ ನೆಕ್ಸ್ಟ್ ಕ್ಲಾಸಲ್ಲಿ ತೊಗೋಣ. ಇಫ್ ಯು ಗೈಸ್ ಇಸ್ ಸ್ಯಾಚುರೇಟೆಡ್ ವಿಲ್ ಟೇಕ್ ಇಟ್ ಇನ್ ದ ನೆಕ್ಸ್ಟ್ ಕ್ಲಾಸ್. Okay, so yeah, telling about today's class briefly, we have discussed about some 4 to 5 basic pancreatic pathologies, starting from pancreas divisum. Andre there are 2 separate ducts of the pancreas draining into the duodenum, because of which a larger part is draining in the small papillae, small opening, because of which there will be increased obstruction, and that will lead to increased or recurrent attacks of acute pancreatitis. So ಅದ್ರ ಬಗ್ಗೆ ಗೊತ್ತಾಯಿತು pancreas divisum ಬಗ್ಗೆ. After that we discussed about annular pancreas, which is like a ring of pancreas which is causing obstruction of the second part of the duodenum, because of which there will be non-bilious vomiting. The investigation of choice is again ERCP, and we'll do duodenostomy or duodenojejunectomy. Then we came and discussed about duodenal atresia, which is the most common cause of neonatal intestinal obstruction, and this obstruction is usually located distal, whereas in case of annular pancreas the obstruction was proximal to ampulla. Okay, na? Hence there will be non-bilious vomiting in case of annular pancreas and bilious vomiting in case of duodenal atresia. Again, management is same for both. After this we discussed about acute pancreatitis, which is the most important topic in pancreas. So acute pancreatitis ke causes, risk factors nodidvi, which is most common is gallstone, and the second most common is alcohol. Other causes we have discussed. After this we discussed the pathophysiology, which is basically the pancreatic digestive enzymes ಏನಿದೆ that will digest its own tissue because of obstruction of the duct, and that will lead to digestion of greater omentum also, and it will lead to saponification and hypocalcemia. And the most common cause of death is usually MODS within 2 weeks, and after 2 weeks it is usually sepsis. What are the clinical features? Usually pain in the epigastrium, radiating to back on the left side, and the patient will be usually sitting with bending forward. And if the gallstone goes and obstructs the terminal ileum, then it will lead to paralytic ileus, and the features will be visible on X-ray of the abdomen. Other than that, there can be hemorrhage in the periumbilical region called Cullen sign, in the flank called Great Turner sign, and in the inguinal region called Fox sign. We'll diagnose it. Investigation of choice is CECT, but it is usually ideal after 72 hours. Before 72 hours, we'll go for serum amylase and serum lipase, and serum lipase is most specific. After diagnosis, we have to treat it, and we'll treat it by fluid resuscitation, oxygen supplementation, and analgesics, basically metimazole and buprenorphine opioids. After that, if the acute pancreatitis is severe, we'll go for total parenteral nutrition. If it is not much severe, we'll go for enteral nutrition through Ryle's tube. Okay, and there are certain scores which we use for assessing if the pancreatitis is severe or mild. Aita. After that we discussed about complications. If we don't treat acute pancreatitis, what will happen? The complications like acute pancreatic fluid collection, but usually it will resolve on its own, and acute necrotic collection. This will lead to necrosis of the pancreas, and what we have to do, we have to percutaneously aspirate, we will have to remove the necrotic pancreas, whatever is there. That is, repeated necrosectomy should be done. If this acute pancreatic fluid collection gets infected and it causes pancreatic abscess, then we will have to do aspiration, percutaneous aspiration using USG or CT, and then we have to treat the infection by using antibiotics. And then if there is necrosis, we'll have to remove the necrotic part. Pseudocyst, pancreatic pseudocyst, it can be seen in both acute pancreatitis as well as chronic pancreatitis. In In case of acute pancreatitis, it will be single and large. In case of chronic pancreatitis, it will be small and multiple. ಆಯಿತಾ? After this, what are the clinical features? Same like acute pancreatitis. Pain abdomen ಇರುತ್ತೆ. After that, non-bilious vomiting ಇರುತ್ತೆ. But if this pseudocyst will usually resolve on its own if it is asymptomatic. If it leads to complications like infection and hemorrhage, we will have to treat it. What is the treatment? Usually conservative management. If the duration is more than 6 weeks and if the size of the pseudocyst is more than 6 centimeters, then we'll have to go for surgery. And what surgery will we do? We'll connect the cyst to either stomach or duodenum or jejunum. That is cystogastrostomy, cystoduodenostomy or cystojejunectomy. So this was all about today's class. Okay, in next class we'll discuss about chronic pancreatitis. Any doubts idya? Okay, if there are no doubts, we can wind up the session.
Thank you.
Okay, thank you.